Hi, my name is Carly Rosner, and today I will be presenting on self-reported outcome measure collection of musculoskeletal patients in an outpatient orthopedic setting. So as I said, patients were seen in an outpatient ortho clinic, and it was located in a suburb in the Southeast United States. There were 3 physical therapists and 2 rehab techs who worked at the clinic. The average patient to physical therapist ratio was 2 patients to 1 PT per hour, and physical therapists would typically see 14 to 16 patients per day. For patient characteristics, this report follows 25 patients in total: 5 patients with knee pain, 5 patients with hip disorders, 5 patients with neck impairments, 5 patients with shoulder pain, and 5 patients with low back pain. Patients were between the ages of 16 to 81 years old, and they predominantly made up of the female gender. The sample had an average comorbidity burden of 1.5 and an average OSPRO yellow flag score of 4. Also, the average time since onset was 84.96 days. For treatment parameters, each patient was seen by a physical therapist for 1-hour sessions, 1 to 3 times per week, depending on the intensity of the impairment. Physical therapy interventions included a combination of therapeutic exercise to improve strength and flexibility, therapeutic activities, balance and proprioception training, core activation techniques, scapular stabilization, and manual therapy. Manual therapy techniques included grade 1 through 5 joint mobilizations, dry needling, soft tissue massage, and mechanical traction was used for patients with neck disabilities. For outcomes over the course of the plan of care, all patients displayed improvements in their scores by the 3rd outcome measure collection. Patients with knee pain improved an average of 41.4 points on the LEFS, while patients with hip pain improved an average of 5.2 points on the LEFS. Patients with neck pain improved an average of 6.6 points on the NDI, and patients with shoulder pain improved an average of 31.6 points on the Quick Dash. Patients with low back pain improved an average of 11.2 points on the Oswestry scale. Patients with hip and neck pain had less meaningful change in disability than the comparator benchmark, but the rates of meaningful change for patients with knee, shoulder, and back pain were higher than my fellow classmates' benchmarks. If you look at the graph below, it illustrates which groups met and did not meet the MCIDs. So you can see that all 5 patients in the knee group met the MCID of 9. And if you look at the hip group, only 1 patient met the MCID of 6, while the 4 others did not. For the shoulder disorder group, 3 of the patients met the MCID of 10, while 2 did not. And for the low back pain group, 1 patient met the MCID of 12.8, while 4 did not. For the neck impairment group, 2 patients met the MCID of 7.5 to 8.5, while 3 did not. As I reflect on this outcome measure project, the lower changes in disability for patients with neck and hip pain were likely due to several factors. The majority of the patients with neck pain presented with chronic symptoms and significant arthritic changes. The focus of treatment for patients with neck pain consisted of dry needling and cervical joint mobilizations, and there was less focus on exercise. It is possible that this played a role. Also, majority of patients with hip pain were active individuals who suffered from quite minor acute impairments. So these patients were highly functional from the start, thus demonstrating less of a change in their disability score. In regards to the rates of meaningful change for knee, shoulder, and back groups being higher than the comparator benchmarks, personally, I feel more confident with treating knee, shoulder, and back impairments as compared to neck and hip disorders. It is possible that my level of confidence played a role in the outcomes of my patient's progress. Also, all patients in the knee group were 1 to 2 days post-op. By the second time point, all patients made a huge strides in their level of function. It is possible that the surgical variable could be the reason as to why the knee group was higher than the comparator benchmark. Thank you for listening.